How about we go ahead and start, and then people join as they can. Is that all right with everyone? Okay. First, I wanted to welcome everyone to the TechRRT webinar today. Can everyone see the my screen right now? Please speak to let me know because I can't, while I'm sharing my screen, I can't see your messages.
Yes, we can see it.
Great. Okay. As usual, because we're not going to be able to see the very, very bottom. Okay. Okay, so maybe we can have a quick round of introductions to let everyone know who's on the call and where you're coming from. I'll start. My name is Andy Kendall, and I'm the TechRRT Program Manager.
I can go. My name is Michelle Gergen, and I'm the IYCF CMAM TechRRT advisor who was deployed to Nigeria.
Can someone go next?
Yes, I'm Najwa Rizkallah, nutrition specialist.
Hi, I'm Jacinta Manyara, nutrition program manager for coffee in Nigeria.
Great. Just one second. Thank you, Jacinta. I think Najwa, you were saying something, but you were very, very low, so I'm not sure if anybody could hear you. Could you repeat, please?
Yes, my name is Najwa, and I'm the nutrition specialist, Iraq country office.
Fantastic. That was great. We could hear you. Okay. Who wants to go next?
My name is Ikenna, and I'm the nutrition program manager for Intersource Nigeria.
Great. Anybody else? Okay, I think we have a few other people, but I'm not sure. Okay, I'm gonna, Shirami, is there anybody else that needs to introduce themselves?
Yeah, and this is also Sanjay from Nigeria.
No, wonderful. Welcome, Sanjay. Nice to hear you. And Kirathi, I think, is with you too, no?
Yeah, we are together, yeah.
So Kirathi, can you introduce yourself, please?
Hi, this is Kirathi Mungai, the nutrition sector coordinator in Nigeria.
Great, thank you. Okay, I'm not sure if there's anybody else, because I said I can't see the participant list. So if there is, please pipe up, and otherwise I'll go on. Great, okay. I'm going to go on just so in interest of time. So welcome everyone. I appreciate you taking the time to join the webinar. The webinar today, is about a recent appointment to Borno and Yobe states in Nigeria by our CMAM IYCF advisor who was supporting improving quality of stabilization center inpatient management of severe acute malnutrition. Hang just a second as we start today's webinar, I'd just like to briefly tell you what the format of today's webinar will be. If I can ask everyone to keep yourselves on mute unless you're wanting to speak, that would be great. If you go to the bottom right-hand side of your screen, you'll see a little microphone, and if you click on there, it'll put yourself on mute and take yourself off as well. Okay, so for today's webinar, first we have the quick introductions and the objectives of the webinar, followed by a very quick overview of the TechRRT, a little bit of background to the deployment, and then presentation from the deployment. We will have something about overall lessons learned and next steps and recommendations. Those two are actually switched around. And then we'll have some open discussion if there's some time left at the end. Okay, so for the introduction of our objectives today, one is just really to foster discussion on the situation in country. We'd also like to share information about the TechRRT deployments. and we want to, in general, to improve follow-up of work from deployments. That's one of the key reasons for hosting these webinars after deployments. So the work doesn't get lost. I'm the facilitator. My name is Andy Kendall. I'm the program manager. The presenters today, we're going to have Kirathi Mungai. He's the Nigeria Nutrition Sector Coordinator. And we have Michelle Gergen. She's the IYCFE CMAM advisor for the TechRRT. So the TechRRT, what is it? It's a technical rapid response mechanism to support collective work for nutrition in emergencies. It's a consortium of 3 NGOs with International Medical Corps in the lead, with Action Against Hunger and Save the Children as partners. Our funding at the moment is from OFDA, USAID. We work in close collaboration with the Global Nutrition Cluster and UNICEF. Our objective is to improve overall emergency nutrition response, and we do that by deploying technical advisors and by providing technical support remotely. Okay, now I'd like to hand over to Kirathi, who's going to start going into the context and the background of the deployments, the background before the deployments. Okay, Kirathi, over to you. And just you can say next slide when you're ready. Let's wait for him to get his mute off. Kirathi, are you there?
Hello, can you hear me? I'm here.
Yes, now we can hear you. Wonderful.
Oh, great. I will give you the overall background of the nutrition situation in northern Nigeria. And we normally conduct the nutrition surveillance 3 times in a year. The last one we did in August 2017. There are some areas or some pockets where we unveiled a gum of about above 15%, and some areas where we have mostly gum between 10 and 15% in most of the areas in Northeast. In Nigeria, we estimate that we have about 450,000 children severely malnourished in the year 2017, and out of which the sector is targeting about 70% of them. That's about 315 of them. And out of the 315, 31,000 of them are severely malnourished with medical complications. So we at the moment have achieved about 4,000 admissions for severe acute malnutrition in the stabilization centers. That's about 13% of our estimated budget. And then currently about 190 for OTPs. As you can see, the progress in the stabilization center was a challenge because of the first part of 2016. The first half of 2016, we had challenges with success. The crisis has affected the health system, and currently the health system is operating about 40%. Over 40% of the health facilities were destroyed, so it's quite challenging to provide nutrition services in some of these areas where facilities are not available. Medical referrals for both medical complication and even severe acute malnutrition is also very limited because of the current security situation, which requires military escort from some of the locations that we are working. We are also facing challenges with the technical capacity of health workers. You see some of the activities that are ongoing are geared towards improving the technical capacity of the health workers. As you can see in the northern part of Yobe is where we have quite serious cases of gum, which is above 15%, and this is not surprising, as these are some of the areas where the coverage of nutrition activities are limited, and also we do not have a lot of stabilization center services in these areas. I'll go to the rationale for the request for TechRRT support in Nigeria. In mid-2016, there was a declaration of a nutrition emergency in northern part of Nigeria, and this drew a lot of attention into the current nutrition situation, which warranted also the scale-up of stabilization center. We also, within the year towards end of 2016 and early 2017, the guideline for inpatient management of acute malnutrition was finalized, and the rollout in terms of training and capacity building had started. During one of the donor visits in early 2017, one of the key areas of recommendation in terms of improvement was on the area in terms of stabilization center, where they mentioned that it requires some strengthening from the observation that they had done during that field. And there are challenges in terms of access and the capacity of the staff in management of some with medical complications, because most of the staff who had experience in working in some of those areas were moved from those areas due to insecurity and were only concentrated within Maiduguri metropolis or the state headquarters of Borno State. And then the other rationale was to also train a team of coaches to follow up on the SC trainings conducted by the current partners, WHO and ALIMA, in collaboration with UNICEF, where they are working in the teaching and referral of people in terms of on-job coaching and mentoring of health workers to improve their capacity and experience in managing some medical complications. And then we also, among the things that were to be done was to develop a stabilization center capacity building plan, and also to look at a scale-up plan on increasing services for stabilization care in Borno and Yobe states. Andy?
I was on mute. Thank you.
So, Andy, do you want me to share my? Oh, sorry. Screen, Andy. Okay, can everyone see my screen?
Yes, we can see your screen, but we can't hear from Andy.
Great. Yes,
Okay,
we can
yeah,
see
I
your
can't
screen.
hear.
Thanks a lot, Karathi.
Okay. Okay. So for the Nigeria TOR, the deployment dates were June 26th, this past summer, and like Kathy said, the purpose was to provide technical and operational advice on inpatient management of SAM with medical complications. And as he said, the deliverables were to really assess the capacity of health staff working with the SAM, a team of coaches to really follow up on SC trainings and improve quality of treatment and the stabilization centers, develop for stabilization centers to bridge. So we started off with the capacity assessment. As you can see in this picture, this is the team doing the assessment at State Specialist Hospital in Maiduguri. And the first step, we started with an admissions analysis, and Karathi actually has updated targets on this. These are the targets as of the deployment date. And I'm actually happy to see that the SC admissions have doubled, which is really great. It shows that there's been improved coverage of the program. So when we look at the targets, we're not meeting our target. The SC target was 28,000, and then the OTP target was 281,000. The SC target, estimated target, is 10%. Whether this number is accurate or not for Borno and Yobe, we're not sure. So we used kind of a standard of 10%, but there was still a 25,000 gap in admissions based on the target. And then the actual, when we look at the actual number of admissions for the OTP, They had 102,000 patients admitted. Estimated 10% of OTP admissions should be referred to the stabilization center, which was just over 10. And this leaves the patient in terms of the gap was still there. So the goal was to assess the capacity in 7 stabilization centers in Borno and Yobe, and they're listed here on the right. In total, we interviewed 43 stabilization center staff members, and in the 7 stabilization centers, they had a total of 122 beds. Then the reported number of OTPs that SCs served was a total of 81. This ranged from 1 to 26, but this is just the number that the SC staff reported of the OTPs they served. It's not necessarily the known catchment area. So then we had a questionnaire that we used that was a standardized questionnaire for this capacity assessment. It consisted of 50 technical questions in 8 categories. And then each stabilization center received a score in the categories. We looked at admissions, the National Nutrition and Medical Protocol, follow-up of patients, discharge, record books and reporting, food item availability and stock management, nutrition, education, and play, and then hygiene and overall stabilization center setup. And here are the results from this capacity assessment. Overall, the score was 75%. As you can see here, Yobe is blue and Borno is the red. And Yobe showed much stronger reports on reporting, yet they were weaker in having knowledge and practice of the nutrition and medical protocol. And just the opposite was seen in Borno. They were much stronger on knowledge of the protocol, but weaker on reporting. And then when we go to look at the specific SCs, we can see that in Borno, we had quite high scores, especially at MTH and Umuru, and these are NGO-supported stabilization centers. MTH is supported by ALIMA, and Umuru is supported by IRC. So they had quite strong programs. And when we look over at Yobe, we can see the scores are much lower. And a part of this is due to a lack of training. Trainings that had been held in Yobe, though they are trying to prioritize training. So hopefully these numbers have gone up. And then as a result of the capacity assessment, there was a capacity development plan that was put into place to help improve capacity and raise these scores. So the overall goal of the capacity development plan was to reduce the under 5 mortality by increasing access to high quality treatment for those with SAM who have SAM with complications. And the first step to that was to strengthen the capacity of existing stabilization centers, and then really to kind of improve and systematize the referral system between OTPs and SCs, because there were a lot of issues that were revealed during the capacity assessment with referrals, from not having means of transport between the OTPs and the SCs, and just lack of communication between the OTPs and the SCs. And then really establish information management systems and to strengthen the monitoring and data collection for all SCs. For a while, that information was very hard to get and or non-existent, and reports were turned in late or not at all. And then to scale up stabilization center activities in both states to help increase coverage and to reach those far out areas. And then part of this capacity development plan was to conduct an on-the-job coaching training. And this is a picture from the training in Yobe. And what we did, we trained a total of 23 people, 9 from Borno and 14 from Yobe. And this consisted of HMB staff, the state nutrition officer, and different local government area focal points. And we'll actually come back to these photos, but the photo on the left is a discussion that's happening at one of the stabilization centers after we conducted the coaching. And the photo on the right is doing a demonstration of the supplementary suckling technique as part of the coaching process. So we did a 4-step coaching process that was part of the training. So the coaches would be sent out to a stabilization center, and they'd spend 2 to 3 days there. And the first step was really to introduce themselves and kind of the goals of coaching, and to observe the work. So just to kind of shadow the SC staff and work right alongside of them, and identify areas of strength and areas for improvement. And then to really work and initiate a plan with the stabilization center team. Now, to initiate the plan, is to really kind of look at the areas of improvement and then do different coaching techniques to help improve the capacity. So some of these techniques that we employed were group discussions, so finding workable solutions to common problems, to assign readings from the protocol in areas that were misunderstood, such as a wall poster with policies or procedures to make available for everyone to see and follow, and then to do demonstrations and assisted changes. And this is seen when demonstrating the supplementary suckling technique. There were during this coaching, there was a lot of issues revealed, such as prescription of contraindicated medicines in malnourished children and different things like that. So we really worked together with the teams to come up with solutions and to work with the doctors and to even getting involved at managerial level on issues within the hospital, within the transfer of nurses from the stabilization center and out of the stabilization center, and kind of trying to improve and make sure that trained nurses were always working in the stabilization center. And then step 4 was to get a commitment in the follow-up. So coaching doesn't stop after the 2 to 3 days, but to make sure the coach kind of calls and maintains open communication with the stabilization center if there are follow-ups that need to be had. And so once the coaching training was done, we developed a scale-up plan because reach is very important. There are certain areas in Borno and Yobe that had very limited access to SC services, so that improving the scaling up where supply chain management, there were some stockouts of RUTS and certain essential supported, so that had kind of WHO had, but those kind of were improved over the course of the deployment. Volunteers in the stabilization centers, making patient follow-up challenging. So this is just kind of referrals and counter OTPs in the SCs. And then there's the stabilization centers after training. Often they'd receive training and then they'd be sent back to the stabilization centers without coaching or follow-up. And so that's why we trained the coaches to really kind of help improve that support. And then there was also lack of manpower in the stabilization centers, meaning that it would be the same nurses working in the SC that were working in the pediatric ward, and they'd have overwhelming case volumes and would really have trouble dividing their time in supporting all the patients. And then limited accessibility due to insecurity, which would result in program interruption. And then the lack of mainstreaming. So there were certain, like CMEM interventions were not always integrated with other programs. And one of the specific programs was the emergency medical teams, to try to really coordinate with them and make sure they had the ability to refer directly to stabilization centers if they did detect a child who had SAM with complications. That's just an example of that. So some of the key priorities for the SC scale-up was to really improve the quality of care and coverage of existing stabilization centers, to make sure the community was engaged and improve the system of referrals between the community, the OTPs, and the SCs, to ensure a smooth supply pipeline, especially with scaling up. Whenever you increase the number of facilities, you need to make sure that the supply pipeline can handle the increased load, and to roll out training and on-the-job coaching plans that are in conjunction with the scale-up plan, and then have a strong reporting system and information management system. So the scale-up framework, the goal is to have one stabilization center in each LGA. And to do this, each LGA needs to conduct an SC assessment to determine whether or not they have facilities and the best way of going about opening an SC there. And then to roll out the training on the inpatient management of SAM, to procure and distribute essential supplies, and then to support the establishment and the actual opening of the stabilization center in the LGA. And then to really ensure high quality treatment by following up with on-the-job coaching and supervision with this team of coaches that we have. And so this is an example of the scale-up plan that was developed during a workshop in Borno with the HMB and the state nutrition officer. And I'm sure this has changed a bit, but we did it in 3 phases. So we had the existing stabilization centers, and then the blue area is the scale-up phase 1. And these were LGAs that already had NGO support, so that there was talks of opening up the priority LGAs. And then we had them listed for Scale Up Phase 2 and Scale Up Phase 3, though this is subject to the assessment and accessibility. And then from this, the key recommendations that came out was really training and coaching to place a strong emphasis on improving the technical capacity of existing SCs, not to forget about those as we're scaling up. And then to streamline training with scale-up plans to make sure there's not a big gap between when the training's conducted and when the new stabilization center opens. And then for the reporting, to have improved coordination with information management at state level, and to strengthen the referral system between the OTPs and the SCs. And this includes transport options, to install a communication system, and to review referral criteria with OTP staff to make sure they recognize the signs and symptoms of patients that do have complicated SAM cases and need to be referred. And then also to improve coordination with other, we touched upon briefly before, for example, distributions. It was noted during the capacity assessment that caregivers often feed the stabilization center on distribution days, so they wouldn't miss out on their distributions. So they don't miss their rations, and so to try to improve coordination so they can remain in the stabilization center and still receive the distribution. And then to coordinate with the emergency medical outreach teams during screenings at community level, can they refer directly to SC, since they are indeed a medical team. And then really to work to have handovers and stabilization center staff are transferred to different areas in the hospital. This is a huge issue with maintaining, once people are trained, to make sure that the hospital rotations between departments don't take away so soon the stabilization center staff, or that they have really strong handovers to make sure everyone working in a stabilization center really has a solid understanding of the protocol. And so I think this goes to TechRRT, actually, the progress after the deployment.
Kathy, you're probably on mute, so if you can unmute, and all yours.
Is it working? I can try to present it.
I'm not sure.
Difficulties.
Yeah, I know he was having technical difficulties before, so we might not be lucky to have Kirathi present it. Kirathi, can you hear us? If you're able to present, that would be great. And if not, Michelle, can you proceed?
Oh, yeah, I'll start, and then if he chimes in, that's great. So after the deployment, one of the really positive things is that funding was secured for 1.6 million, and then a majority of which was to scale up stabilization center services. And this was a direct, very positive result of the deployment, because once plans and coaches were in place, that made it easier to kind of have a plan going forward and how to best utilize the money. And Kathy, are you here? Oh, I thought I heard him. And then partners were identified and are on process to establish stabilization centers in 5 different LGAs. So that's really positive that they're moving forward with the scale-up plan. And more funding was allocated to the nutrition sector through the Nigerian Pooled Fund, which will be utilized to scale up stabilization centers in Yobe, which is really exciting because Yobe was struggling a bit with trainings and quality. And the training of 30 additional health workers on stabilization center, the inpatient protocol, was conducted through the World Health Organization. And then increased admissions and better management of beneficiaries in the SC, where capacity strengthening has been done. And I think this was seen in the numbers that TechRRT presented in the beginning, how the number of admissions had doubled since the end of the deployment. July and August, the beginning of the year. So you can see a direct improvement in quality. Then lessons learned, Andy, will go to you.
Great, thank you, Michelle. Okay, so just Thank you, Michelle. Thank you, Karathi, for the presentation on the deployment. I think it's really interesting deployment. To be honest, I think it was really a model for the TechRRT. And some of the lessons learned, in fact, from this deployment are quite interesting. Um, there aren't many there, but there are two. In fact, on this deployment, there was really excellent collaboration, making the deployment successful. Partners really contributed to the success of the deployment by contributing to the assessment and the trainings, etc. It was really a joint effort to try to improve the quality of stabilization centers, and it seems to have been very fruitful. Another lesson learned is that there was a really long wait to get the deployment off the ground, but when it finally was able to, it was fruitful. Basically, the deployment was under discussion from around the end of February, early March, and it actually finally took place the end of June. Normally, TechRRT deployments, we try to get them off the ground within, say, 3 weeks of the time when the discussion starts. It's obviously a rapid response mechanism. And in this case, it was really long. As Kirathi can testify. I must have been contacting him all the time to follow up on how it was going with the TOR development. But in fact, that long wait and all the work that Kirathi and Sanjay did within UNICEF, within the cluster, within different parties on all different levels, it meant that actually we had the optimal conditions for Michelle when she arrived on the ground. Everyone was really prepared to move forward, and everything went super fast when she got there. So maybe it's an example that although it takes time to plan it, maybe that long planning and the discussions that take place between the different stakeholders is really necessary to make sure that you get the best from that short deployment time that we have. This deployment was, I think, 5 weeks. We normally have up to 6 weeks, and so in this case, since everyone was ready to go, was able to have quite a big, be quite fruitful. There was no time lost, I'd say, which does happen on some other deployments. Okay, Michelle, do you want to go on to the next one? Okay, so that wraps up our presentation for today. Now, first, I'd like to go to any questions from any of the people participating today. Before any questions on any of the contents or broader questions, we're happy for you to either speak or write them in the chat window, whichever you prefer. Okay. There was a note that came in towards the end of the presentation from Ikenna. So I don't remember exactly what it was pertaining to. There's 6 LGAs. Magumeri is a different LGA. I think this was something that you had highlighted, Michelle, maybe from the progress after the deployment.
Okay. Oh, okay.
Okay, if there aren't any questions, then I guess it's open for discussion. Anything you want to raise, please do feel free. And if maybe I can give a question to sort of spur some thoughts. I think I've got 2 questions. I think I'm going to start with one about emergency situations that cover quite large areas. There's always the question about how to scale up and how to do it where you can ensure quality. I hear somebody. Does somebody want to talk? If somebody's just joined, please do introduce yourself in the chat window. Okay. So as I was saying, in large-scale emergencies, quite often inaccessible air where lots of areas are inaccessible. We tried to work out how to scale up and how to scale up rapidly, having a good reach, but we struggled to ensure quality. What have you had experiences in ways to have you had experiences trying to scale up and how you've been able to maintain quality?
Okay. Your darling is suffering you.
I think there's somebody that needs to put yourself on mute. Unless you're talking to everyone. Thank you. Chukwuma, I don't know if that's how you say your name. Are you?
Mamarachi. Thank you. Hello?
Hello, everyone. Is Aisha, are you trying to talk, or Chukwuma?
No, you're asking how I introduce myself. I said it's Mamarachi Caritas Nigeria.
Okay, wonderful. Welcome, welcome. Sorry, Chukwuma, I didn't hear what you said.
I wasn't actually saying anything. You were asking how I introduce myself. So I said it's Chukwuma Amarachi from Caritas Nigeria.
Ah, wonderful. Sorry. I just see two people talking. I didn't hear the name. Okay. Thank you for that. And Aisha.
I remember okay, yeah, because I was looking for him. What happened now?
Okay. Chantal had some input. Chantal just said she's come back from Yobe Borno headquarters field visit, and she understands the challenges that are presented.
Okay.
And that we need to work together to improve the situation.
Please, can I tell you to turn off the camera?
Oh. Okay. If everyone can put themselves on mute if you're not trying to communicate with everyone, that would be great.
Okay, video. I'm not hearing anything again.
Okay. Chantal, did you want to say anything more about your experience from your visit?
I'm not hearing anything.
Okay. Okay, I'm not sure if everyone could hear my question before. Okay, you're not able to speak. It sounds like quite a few are having some problems. I think we're experiencing some technical difficulties. Aisha, are you trying to talk to everyone?
Are you hearing?
I'm not sure if you go by Aisha. Aisha Kakabello, are you trying to talk to everyone on the webinar?
I'm not hearing you.
Okay, can you maybe move to your microphone? It's in the bottom right-hand corner of the screen.
Okay, you're going to join me.
I thought he's on it. Even if you don't finish.
Okay. Okay. Jacinta, I see your message. I understand the internet hasn't been great. I'm happy to share the slides. As everyone has registered, I'll be sure to share them with everyone after the webinar today. Okay. Okay.
I'm
Now,
in, Andy. Sorry, I got
great. Welcome. Great. Welcome, Michelle. Okay. I'm not sure, Chantal, can you try speaking again? It looks like everybody else is on mute.
sorry.
Would you mind trying? Okay, so Chantal's just written that she saw a shortage for drugs, shortage of staff, and also lack of capacities and knowledge of staff. And they tried to work on some strategies. Okay, understand your mic doesn't work. Okay.
Yeah, so we actually worked with ACF in Yobe, Aisha, and also with Dr. Justin in Borno. And I think they were starting to run the nutrition sector, and we've actually trained coaches with ACF to help really improve, along with LGA focal points in Yobe. So hopefully the support will improve. And I know there was also discussion of linkages with training. So hopefully they can work together to really improve all those challenges.
Great. Okay. Does anybody have anything else that they would like to share or discuss? Okay. Or now that I think everyone can hear me again, one of the question that I'd asked was any experience with scale up or how to try to ensure quality while scaling up, or in situations where access is difficult, ways to manage remotely, ensuring quality. Okay. If not, then wait. Okay. Okay, so there's been two things posted in the chat window. Chantal said it's a good question, and they're they're looking for. Wait, I don't understand. But we probably for the remote looking.
I can. Yeah, so supply breaks are really challenging. I don't know if Karasi and Sanjay, I know that you guys work quite closely with the state nutrition officers and the distribution of supplies. I'm not sure if you have anything to add about the issue of supply management and stock shortages.
Can you hear me?
Yes, we can.
Yes.
Go ahead,
the issue about supplies and medicaments for the stabilization center. I think we've been able to secure funding for this one through UNICEF in terms of the therapeutic meals and also through WHO in terms of the stabilization center kits and other equipments required for the stabilization center. So at the moment, but the only thing is that for most of the partners, they have to work with UNICEF to develop this year to be able to access these therapeutic meals. But for the ones with WHO, once we identify that the stabilization center is operational, then these are supplied directly to the facility. So this is one of the things that we are doing to ensure that we have supplies and medicaments in the stabilization center.
Thanks for your input, Karathi. Okay, so maybe Karathi, do you have any input on the question that I asked? In your experience in Nigeria in general, how have obviously with this with the support from Michelle, there's work to ensure quality while scaling up, and there's some things with how to manage remotely. Do you have any other things that you'd like to add on trying to do this? Not necessarily just with Stabilization Center, but in general with nutrition programs. Okay, so okay, I'm going to ask on the chat. Okay, as everybody sees, I'm asking everybody in Nigeria. I think we've got several people attending today from Nigeria. So it's how has Nigeria been able to scale up and try to maintain quality of programming, not just for Stabilization Center, but for all nutrition programs? And the added question specifically when thinking of difficult access and remotely managing programs. Anybody want to share experiences?
Yeah. Yeah, so regarding the quality of nutrition program and current scale of strategy, so considering in the context of Northeast Nigeria, we have used, hello? Are you hearing?
Yes, we can hear you, Sanjay. Please continue.
Okay, thank you. So for we have used this strategy mainly to scale up nutrition program based on the context. So in Northeast, there are some of the area where health facilities are functional. In those areas, we have integrated nutrition program like CMAM, IYCF, and MNP with the health facility. In all health facility, we have set up integrated nutrition package. There are some of the area where health facility structure is not available, and they like IDP camp and a scattered community. In that context, we have set up around 56 mobile outreach nutrition team. So those mobile outreach team are going once a week in a particular community, providing the treatment for 1 week, and then again going for another location. So in 1 week, they are covering 5 sites and providing the services on weekly basis. So this is the strategy for area where health facility are not functional. Our third strategy is scale up through the outreach site. Like some of the settlement, there are some of the community which is far away from the fixed health facility site, but they are easily accessible. In that place, we have set up satellite OTP site. That satellite OTP site is providing service 5 days a week, as the population is densely located there and case load is very high. So in this way, based on local context, to increase the access of service, we have used these 3 strategies. At the same time, we have identified around 3,400 community nutrition volunteers, and on monthly basis, they are doing a screening of 700 to 1,000 children in their catchment area and referring those children to the OTP. So in this way, we are working with 2 strategies. One, increasing the access of service to the community, at the same time creating or strengthening community mobilization component to increase the demand of the service. And we are working closely through the State Ministry of Health and Hospital Management Board to ensure it is integrated with the government health system for the sustainability purpose.
Great. Thank you, Sanjay, for the information on how you guys are trying to achieve scale and maintain quality. I think that Ikenna also has something to add, but it sounds like he can barely hear. Ikenna, can you speak? It sounds like internet is very bad. So he wanted to add, I think, some of the things, Sanjay, you also mentioned. He said, I'm sorry, I don't know if you're a woman or a man. There was a TOR in the nutrition sector for the recruitment of a community nutrition mobilizers, which helped to maintain program quality with regards to case identification and follow-up. And this also helps to increase community participation and ownership. This is for partners who have had the funding for this. So I think that complements, Sanjay, something that you had touched upon as well, that you kind of had written before you mentioned that strategy. So thanks for that input. Anybody have anything else they want to add? Could be somebody from another experience from another country with similar issues of access and just the size of the emergency that it's difficult to reach scale. Okay, if nobody has anything else they want to add, I really appreciate your joining our call today, and I know it's been a little bit difficult with the internet connection, particularly for those in Nigeria, I think. But we're very happy to have you attend. And hang on a second. Okay, there is a question from Jacinta about what's the experience been on how women in stabilization centers receive their general food ration? Has that been sorted out at all? Maybe Kathy, you have some information on this? Or Michelle, any information? No. Okay. So I apologize, Jacinta, no answer, but I'll circulate the question, and if you can maybe type your email address here, then I'll pass the question on and hopefully get an answer to you, okay? Sorry not to be able to have the input now. Okay, so Ikenna said it's usually much easier when it is the same partner that's implementing both activities. Okay, that's true, of course. Okay, thank you, Jacinta. Okay, Kirathi's just written to answer. The household with a mother in SC is represented by any other members upon notifying the partner conducting GFT that the mother is in the stabilization center. Okay, so it sounds like it's important that the partner has to notify the organization doing the general food distribution that the mother is in the stabilization center so that she can be represented by somebody else. Okay. Jacinta, is that clear, or do you need any further information?
I think I'm back. Sorry, I can't hear, and I missed the question. I got disconnected.
Okay, no worries, Michelle. It's about general food distribution and for for people who are in the stabilization center. So the question was, any experience on how women in stabilization center receive their general food distribution rations?
Yeah,
Kirati's
this is
answered.
actually a really good question. Oh, he has. Okay, great. Perfect.
Yeah.
I missed it all. Thank you.
That's all right. So he wrote his answer, and I also said it. Okay. Are there any other questions? While I'm waiting just to see if there's any other questions, I'm just writing down the email address for the General TechRRT email address in case anybody has anything they want to reach us for, whether it's questions about the webinar or any questions generally about the TechRRT or wanting to request support. I should also mention that the TechRRT has recently expanded our scope, and we are able to actually provide direct assistance to individual organizations who are interested to improve the technical quality or the scope and the scale and reach of their programming. Feel free to get in touch if you're interested to have an advisor deployed to an emergency country. Okay. I don't see any other questions in the meantime, so I think we're going to close there. And I appreciate everyone's attendance. Thank you very much. And thank you to Michelle, Kirati, and Sanjay for being here to present and for what seems to have been a very fruitful deployment. Thanks, everyone.
Thank you. Thank you.